Hi, this is Hear the Raw podcast. I am Paul Schneider. As always, you can follow us on TikTok at here underscore the underscore raw and on Instagram at here dot the dot raw. And this podcast is available on most podcast platforms. There are a few that have been impossible to join. I think the likes of Heart Podcasts and TuneIn are the only ones that really I'm not on, but Deezer, Apple, Amazon, Spotify, the list goes on. We are available on all of those platforms. On this podcast, usually, or I would say the most of the interviews I've done have been survivor interviews mostly. There have been some very fascinating interviews with people that are specialists in various areas of professionalism within the cancer world. So Paul Burns at Thor for the photobiomodulation interview that was done a few weeks ago. There was Ingrid, who is a specialist in pain management. And today I've got somebody I have been trying to get on for an interview for quite some time. Great to see her today. We are aware of each other and have been for quite some time. Emma Hallam has joined me. Hi, Emma.
Hi, Paul. Thanks for having me.
Um, so Emma is a Macmillan so I can't go onto my text on my other email while I'm on this call, Emma. So why don't you go through exactly what you do? Because I'm gonna don't want to get it wrong.
Okay, so I'm a Macmillan consultant therapeutic radiographer, and I lead the Nottingham Late Effects Service at Nottingham University Hospitals NHS Trust.
So
And
amazing.
yeah,
And what I wanted to start with was I was saying to you before we spoke that I obviously Googled your name earlier today and was very impressed that Emma Hallam uh, with the third word Nottingham came up in the search options within Google. So I was very impressed that that's even beyond page one. I was completely impressed. Then looking you up, I saw that you are an award winner. I think just found out from you a multi-award winner for the work that you do. Talk us through that because I think this will lead us nicely into what you do.
yeah. So first of all, just to say, I set the first service of its kind up back in 2013, and that's the
Yes.
Nottingham Late Effects Service. So a
Yeah.
service that is there to support patients once they've completed cancer treatment and are living with the often disabling psychological and physical consequences from that treatment. And in particular, we're talking about the radiotherapy and the chemotherapy.
Yeah.
For our work within this field, we first of all won a quality and care award for managing long-term conditions in 2016, and the same year we also won a Macmillan Excellence Award for innovative service. And then back in 2019, I think it was now, I won another Macmillan Excellence Award for basically called Whatever It Takes. And this is about going above and beyond for patients, and literally doing whatever it takes to help the patients that you support. So, yeah, I'm very proud to have
Yeah.
been a part of those nominations and to have won them.
Yeah, amazing work, clearly, and thank you for everything you do. First of all, the whole topic here is an interesting one. Lots to talk about. The so you specialize in late effects. Now, some people would say is that the same as side effects. There's that discussion. It is and it isn't. There are ultimately side effects that are brought on later on as a result of radiotherapy and possibly other treatments, chemo, one for example. The thing I want to talk about is you were part of setting up the first laser effects clinic, which is, if I'm not mistaken, funded initially or primarily or mainly or solely by Macmillan.
Initially by Macmillan. It was a
Yeah,
3-year funded project. And then we became trust funded essentially. And then we went back to Macmillan in 2019 for some further funding for me to help really specialise in head and neck late effects,
yeah,
and to look at the patient reported outcome measures and screening tools that we use to monitor patients now for late effects. So, yeah, without Macmillan, we wouldn't be here. Macmillan have set up many late effects services throughout the UK. Um, we just need funding to be picked up going forward, and that's
yeah,
what's lacking, sadly.
yeah. So I'm aware of Sandbostock, I think down in the Cheltenham area, that kind of
Yep.
area of the world. She's also doing some amazing work. Met her a few times. How many clinics are there now across the UK? Do you know
So
roughly?
I think there's so Sam Bostock's clinic is part of the Southwest group, and they've set up a regional Southwest late effect service now, led really by Lisa Durrant, who's kind of my partner in crime, really, and set up just after we did. Um, um, but I think this when we've also set a therapeutic radiographer-led specialist interest group that Lisa and I set up a couple of years back now, and from that, I think there's about 26 services set up. The problem is that not all we really know about the radiographer-led services, but some services only do certain tumor sites, so it's quite hard to quantify that. But I believe Macmillan are trying to do some work at trying to really establish services and a list of these a directory really of late effects services. The problem is some services start and then they don't get sustained funding. So services that might have
Yeah.
been around 3 to 4 years ago are no longer around. So it's quite hard to keep tabs on it really. But we believe there's around about 26 radiographer led services either setting up or about to start seeing patients.
And how does somebody that is suffering with any form of side or late effects, just using those two words because of the way people refer to it, how does someone find out about where their nearest clinic is? Is it the Macmillan website mainly?
So you can try Macmillan, but the best thing to do is to go back to where you had your treatment because it is
Right.
radiographers like myself that are setting these service up and are really because we need to take responsibility because we were the ones who planned that treatment and delivered it. And this is where a lot of these services are because we know it's in the radiotherapy service specification guidelines that late effects should be managed locally. Would you like me to clear up about side effects and late effects so we're clear about what this comes through? So basically, a side effect is any side effect that you get at any point, either during or at any many years, decades down the treatment. That's a side effect. What a late effect is essentially a acute side effect, so a side effect that you get on treatment that doesn't settle, or one that can develop many years, many months, many decades down the line that is
Yeah.
directly related to that treatment that you had. So that's what a late effect is. Some people talk
Yeah.
about acute, so on treatment effects, then these long term effects, which tend to be the 3 to 6 months, and then we class it from 6 months onwards for a late effect.
So, if I'm not mistaken, with cancer survival rates across the board, so it's a generic survival rate, I think in excess of 75%. It's considerably above, I think, and climbing. I think the late effects clinics and what you do and the need for what you do has arisen ultimately on the back of the success of the survival rate for cancer. Am I right? People
Uh,
weren't, yeah, years ago, people weren't expected to live so long.
yeah, yeah.
And now people are living with the effect of survivorship.
Yeah, and all we ever seem to really focus on is toxicity on treatment and survival rates and diagnosis. We know that late effects of cancer treatment are going to become a huge drain, particularly on the NHS, for those in the UK. And we know that by 2040, there's going to be over 5 million people living with and beyond cancer. And when we see how many patients that we're seeing with these consequences being bounced around other services, this is the problem. A lot of it is unrecognised and not attributed to either the radiotherapy or chemo treatment. And
Yes,
that's why services such as mine and other late effect services are so in need, but trying to get the funding for them and to prove our not just our worth but our cost benefit is very difficult.
yes,
But at the end, every patient who comes through our services, and that's every late effect services within the UK, the actual quality of life improvement that we give and help these patients with is phenomenal, and that's why so
yes.
many people are shouting about what we do, but trying to make somebody listen and the commissioners commission services is very difficult.
Yeah, I'm aware of that. So on that, the I've had some interesting chats around this. Because the typical KPI for cost justification, I think, for the NHS, you'll know better than I would, but would typically be, how many beds is it freeing up? How many free appointments is it freeing up? That kind of area of KPI, I'm guessing. The problem with I guess, justifying cost for a later flex clinic is you can't just go and say, well, 20,000 people have been in and out of this clinic this year, for example, and they're all living much happier. They're all great and having a good time.
Yeah,
That's not something you can
yeah,
report. How
yeah.
do you report in the success of what you're
Well,
doing? Because the
it
success is incredible.
yeah, it's very difficult, and Lisa Durrant, particularly and her team down there, are doing some great work at trying to really look at that cost benefit analysis, because we can take one patient and say, well, you went to the GP 70 times before you got to see us, and we could have stopped you going to that GP 70 times if you'd come to see us. We stopped you having a scope or this investigation. But the way we're making the benefit, and particularly where I'm making the benefit with head and neck, is that we are getting people's function back and we are getting them back to work. So whose cost benefit is that? If I get a patient off a feeding
Yes.
tube, it's the GP that's probably paying for that then by the time they've left cancer treatment follow up at 7 to 8, 10 years out of treatment. So how can we ever cost this? We probably can't. We can't do it in terms of bed day. Yes, I can do in terms of I got the patient off this pain medication. They're now not having the feeding tube. But actually, to quantify that out for every patient, and remember that with radiation-induced fibrosis, it's a progressive sclerotic disorder, which I'm going to say we've never really had any treatment for it until we found photobiomodulation therapy, and that's something I'm trying to research and get the evidence base for it. But until then, you're still this fibrosis is going to keep coming back. So it's about helping and supporting these patients live better with, not necessarily curing them. So
Yes.
the cost benefit of actually supporting these patients might be a lifelong then that they come into your clinic for. So therefore, you're going to look like you are costing more money.
Yes.
So it's where you're making those savings. Well, we know we're doing it because we're getting patients off benefits back to work, but justifying that is yeah.
So, what percentage of GPs are aware of late effects clinics? Because
So,
typically, just the reason I asked that is typically what, so, I discovered you guys through my own journey, obviously. And, when I had my first issues, I went back to my consultant.
mm,
Oh, it's just this, it's just that, and sent me
mm,
to speech therapy.
mm.
Um, didn't deal with many of the issues I had. And it went on my GP, I didn't have a clue who to send me to.
Yeah,
Um,
and it's tricky. I mean, when we started in 2013, we went to every single GP practice within in Nottinghamshire, and patients, and we told every single oncologist, every single surgeon that was within our trust, and then
yeah,
patients still don't get sent to us because the problem is when you go and see that consultant or whoever you see, they don't look at your subjective bother, what this matters to you. They try and think about, well, do they think it's enough of toxicity or severe enough to refer you on to a service? Now that might be a pain service if they don't know about a late effects service. We spent 3 years advertising our services. I am now saturated with patients. I haven't got time to keep going advertising. We got very few referrals from GPs. We did primary learning team events. We went to every single MDT, the district nurses. I haven't got time to do that anymore because our clinics are full with patients and we get referrals in. But there's lots of patients who come to us and say, I never knew about your service.
yeah,
I mean, I picked somebody up from the Swallows conference last year who was 20 years out of treatment, has been part of the Swallows for a few years, and had never been referred to me in Nottingham. So, it's sometimes about making those dots. What I believe it's about is empowering the patients. And that is why now every single head and neck, well, every single patient who has radiotherapy in Nottingham, at the end of treatment, they are informed about the late effects and there is support available for you. It doesn't mean they'll remember. And then with our high risk group, so for us, it's our head and neck patients and our gynecological patients, they are all prospectively followed up with we're calling it a patient reported outcome screening tool. So it's a questionnaire that we have designed that screens for every single possible late effect, both physical and psychological, and they can fill that in. Now they're giving it every other year. The head and neck start about 4 months out of treatment, and we use that as a screening tool. Now it's a text and text, so they don't have to come in to fill it in. And if they don't fill it in, it usually tells me actually you're doing all right. But it gives the patients the power to say, well, I have got problems with my swallowing, but it's about what matters to them. So it'll be, I've got a dry mouth, but it doesn't bother me. Or it might be, I've got a dry mouth and I really want to speak to somebody about it.
yeah.
But the thing, the beauty about these questionnaires, it's about what matters to the patient. The other thing is, and at first, when I first started, came up with this idea, I thought patients won't want to be bothered and filled in. I've got patients now 7 years down the line, they tell me they feel it's their safety net. And by 10
Wow.
years, I mean, I'd carry it on for life if I can, but I can't because I just can't, the amount of questionnaires of going out. But actually, a patient will know by the end of 10 years of filling probably 6 of these questionnaires out exactly what I'm looking for. So the patients need to be educated that if they start to get a pain in their neck or they feel that restriction, gosh, could it be that radiotherapy? Because how can we expect GPs to know? Because they're not experts in radiotherapy. And that's
Oh,
why patients bounce around so much.
yes. So I remember I went to see my daughter riding her horse, and I was at the time, I don't know, I think within the first 6 months after treatment, I reckon. And I'd had things like trismus set in. I'd had just other things that were going on. I had these horrible cramps. They weren't radiation fibrosis moments. I don't know what you call those. I've got that now, by the way, which
Mhm.
we can have a chat about that in a second, and especially about photobiomodulation, because I think there's a good chat to have around that. But I started to realize that something my consultant surgeon said to me when I went back to see him after my treatment. He just said to me, Paul, it's going to be relentless for you. And I said to him, what do you mean? And he said, well, you know what relentless means, right? I mean, his bedside manner isn't the softest, I'll be honest. But I said, I do know. He said, what I mean for it's going to be relentless for the rest of your days. The side effects will be relentless, continual, ongoing, one after the other. And I was sitting there having some issues, and I thought, what does that mean? I looked it up. I did the classic look up. The list is as long as your arm,
Mm.
and a lot of
But
them are not. Yeah,
we don't know who's gonna get it and who isn't, and this is a problem. Let me just,
right.
trying to read oh, where have I put it now? So, I've got a quote that a patient, told me, not from our centre. Where is it? Where's it gone? Um So this is a quote from a patient from who attends another support group that I very much my heart lies with them, um, and um, and this is what their consultant said to them when she challenged him about this consultant about the late effects services, and he said, "Whilst I can see the value of late effects clinics for children and for patients who've had treatment in their pelvic area." For head and neck patients, the late effects are known when the decision is agreed for treatment and are irreversible. So basically, why? Well, my why is because we have a duty of care to all of our patients to validate what they are going through. Even if I don't think there is now, because of photobiomodulation therapy, without a doubt, we are making a difference. But before then, we would see the patients. We have some patients that I see in my joint clinic with a speech and language therapist that we know we can't move their swallow on, but every year we offer them an appointment to come and sit and just tell us and have a chat how life is. Because you'll probably know, Paul, patients decide, they get fed up at telling their family and friends all the time about how they're
Mm,
how they're experiencing,
yes.
because nothing changes and you want to
Yeah.
try and move on. So to give patients an area where they can come and sit and speak to somebody, even if they know we can't do anything about it there and then. I mean, we never know because things are always developing, but it's about validating how we've left these patients, and that is the importance around late effects services, along with helping a patient to understand why they've been left like they have. We know that we can drop pain scores, so a pain scale of 0 to 10 being your worst pain, by 2 to 3 points, not by prescribing some more medication, but by explaining to them, this is what the radiotherapy has done, this is why you've got this damage, and this is why it is. You can then lead them towards acceptance, and that drops pain scores. And it's that level of understanding and that explanation, because that is what they don't get from other professionals. They might go and see the surgeon, but they don't sit there, they'll just go, oh, it's that radiotherapy. Yes, we know it's the radiotherapy, but why? Why has it done this to me?
Yeah.
So that is why it is so important that these services are available.
Well said. I remember when I went to an appointment with my consultant, I walked in, I was not in a good place, had been dealing with a number of side effects, late effects, and just generally depression, if I'm honest,
Yeah.
which is an effect anyway. And he walks in, he said, what's the matter with you? And I said to him, well, life after. And he said to me, well, that's survivorship. And he said, it's so matter of fact.
Yeah.
And I said to him, that's just a word to you. I
Mm.
said, but I live it.
Yeah.
Which moves me on to my next point, which is how many people patients that you talk to, will tell you that the people around them, so work, family, and friends, ultimately either don't believe this list of issues they have. It's just cancer. I know somebody that got on with their life when they had cancer. I think some people think cancer is the same cancer. It's just
Mm.
where it is, not what
Yeah.
it is.
Mm.
Even though there's hundreds of different types of cancer. But what is that a big thing that gets
Mm.
discussed as part of your clinics?
Yeah. Massive. Massive. Patients will say to me, their friends and family will say, "Haven't you done well? You've beat that cancer." And they just stop explaining how they are, because inside they don't feel they've beat the cancer, because, and many of them will say they'd rather have not had the treatment. Now, when you're
Yeah.
at that consent process, you just want to be cured, don't you?
Yes.
So you will, I say, take anything, uh, you know, and also I think we're not. whilst with the Royal College of Radiologists now we have the consent forms are really good now, they're much better than they were before. It still doesn't pertain what that will mean to that patient. So you might say to a patient, "You're gonna get a dry mouth," but what does that mean? That's the difference between me needing some water now while I'm drinking because 'cause I'm drying out a little bit, to not being
Yeah,
able to deliver a lecture and lose my job, to not being able to kiss my partner anymore, to be able to not being able to
correct.
swallow my food. It's different for
Yes,
everybody, and that's your dry mouth. Before we
yes,
even start, and the thing as well is what I don't think anybody, well, sorry, patients who go through it do, but a lot of professionals and friends and family don't understand is the cluster effect of all these of all these late effects that we leave patients with, because it isn't just one, is it?
no,
You've got fatigue because you're living with pain, because you're not sleeping well, you've got a constant sore throat, you've got twinges in your neck, you've got spasms in your neck. That's before we even get onto the dry mouth and the problems with the pH of your saliva, the thickness of your saliva. And just one, if we can just get rid of one thing, maybe that'd be great, but everything else doesn't. And this is where the importance for me is these combined clinics, particularly for head and neck patients. So these multi-professional. So for me, it's myself as a therapeutic radiographer, the dietitian, the speech and language therapist. We also have input from the lymphedema team. Um,
right.
and it's about this multi-professional where we are not working unilaterally, because at one point I was putting a patient onto some amitriptyline, so a medication for
Oh, that is
neuropathy,
awful stuff.
because of she had this patient had burning tongue syndrome. The
Right,
speech and
yes,
language therapist kept taking her off it because it was making her mouth dry, but we weren't going to get her swallow forward to progress, to improve, until we helped with the burning tongue syndrome. So very
yes.
quickly we realized that working together with the patient at the center to meet their needs, all looking at what matters to the patient. Because, obviously, what matters to speech and language therapist is the swallow ultimately. Not ultimately, they're very holistic, but that's what their main role is. But actually, that might not be the patient's focus. They might want their pain sorting out rather than trying to get back to eating and drinking. So it's these multi-professional clinics where the patient's at the heart, but the other really important key of that is that we can work on what's important. So for me, we certainly now we know we need to reduce the lymphedema, which is nearly always present, whether that's internal or external. Work on the fibrosis. We've got to break those things down before we can start doing the rehab and start working on the swallow, or even range of movement, whatever that may be. And the other thing that we do by us all being in these multi clinics together is that we're all saying the same thing. So, at one point I was given a set
Yes,
of exercises, the physio might have been, speech and language might have been, the lymphedema team might be. That's 4 sets of exercises essentially for
yeah,
the same problem, really, but we all come at
yes.
it slightly differently. So we've designed exercise plans now that include all of this, because these patients have to do this for life. So we've got to make it where, yes, we've got to inform the patient about this is for life and this is the nature of radiation induced fibrosis, but actually, what are you going to actually commit to? What's the compliance going to be like? And we find our compliance is a lot higher now since we've started working together.
And as a laser flex clinic, you work across multi divisions, don't you? And also hospitals and trusts as well to gain access to services for patients. Is that right? Or
Only within Nottingham and Nottinghamshire. So yes,
right?
we have like three main hospitals and two big trusts. So we work
Yeah,
across those, yes. But it's very difficult because we haven't got the same services that the Southwest team will have. It's just how things
yeah,
are. We are in the East Midlands. We have set up an East Midlands late effect service, trying to replicate what the Southwest have got. We don't have any funding for it, but we're trying to somehow work together to try and, even if we just go back to our individual trusts and say, well, in Nottingham you can get this, but in Derby you can't, and vice
yeah.
versa. Try and because it shouldn't be a postcode lottery, but it is.
Yeah, it is sadly, but you can still work across multi departments, can't you? So you
Yeah,
can
and that's
you
what we
can
do.
access, yeah, yeah,
Yeah.
fantastic. So you can find. I remember talking to Sam, telling me that she discovered a particular department that sat within I don't know, a clinic somewhere that no one had ever heard of that provided the service that somebody needed. And I think,
Mhm.
when I heard about that and also the benefit that it brought this particular patient, it just goes to show the length that you can go to, the prep that you can go to
Yeah,
get
so
someone what they need.
every single late effect service really has kind of followed a bit of our model, and that was literally myself and Liz Stones was the other therapeutic radiographer who set this service up with me. She's retired now.
Yeah.
We miss her dearly, but we went knocking on doors. We went to every single department, every single clinic within our trust and the trust that we could within Nottinghamshire, and every
Yeah.
single community clinic that we could get hold of to knock on and say, "What service have you got for patients?" And that's how you find out, and that's how you do it.
Yeah, amazing. Let's talk about photobiomodulation then. So when I was going through my treatment back in 2021, um, I was introduced to Thor.
Mhm,
And as you may well know, Paul Burns came on and did a podcast, certainly the last couple of months, I think it was, that went live and published also very recently. Um, and I got access to the PVM
mhm.
kit. Now, at the time, I was suffering, I would say my worst. So I did okay through my treatment from a oral point of view, but that was through meticulous and obsessive round the clock usage of everything I could get in my mouth to treat my mouth, if I'm honest. So I did okay, but by week four, start of week four, end of week three, I was really starting to suffer from a mucositis point of view. But the PPM, I believe, kept that at bay. The
Mhm.
photomodulation kit. I went into a treatment room in the old Cheshire office, and I
Yep.
self-administered.
Mhm.
Now I also found the bed. I don't know how much the bed is used as part of late effects. I know it's very expensive and therefore is
No,
not
it's
probably
not.
used.
It's not.
But the difference to my fatigue level was
Mhm,
unbelievable and witnessable in the moment. I come off that 10 minutes later. I walk in, dragging my feet.
mhm.
I'd walk out like a spring chicken. It was quite amazing. However, the PVM kit is quite amazing. And interestingly, Paul said I should be using that for my radiation fibrosis. So what's the deal there? How are you finding the kit? I know you're a big advocate of it.
Yeah, so first of all, to say to you, there is no evidence for this. There is no published evidence for this at all. It is completely different using it in the late effects setting to what you used it for if with oral mucositis, because that is an inflammatory response. And yes, we know it has been proven that it has benefits, although it doesn't benefit everybody. Okay.
Right.
But the
Yeah.
results are great. Certainly some centres, they are reducing their medication costs. Patients aren't using their feeding tubes. You're keeping patients swallowing for longer, so therefore we may
Yeah.
delay radiation fibrosis. That is what we don't know. What I will tell you is the 8 patients that we did on treatment, every single one of them has been back with late effects in my clinic. But that was only 8 patients. So I will not say it prevents late effects or the buildup of radiation fibrosis, because it's about lots of other things as well. But 2 years ago, when Paul came here with Chris from the Swallows, to get us to use it on treatment, right away I didn't. I wasn't interested. That's not. I have a We have a fantastic radiographer, Sarah Lambert, who supports all the patients through treatment. That is her job to do that, and my remit is late effects. And
Yeah.
I knew that some private lymphedema clinics, and I manage all the early head and neck lymphedema, because we know that most patients will get a buildup of edema within the tissues post radiotherapy, and I'm talking 3 to 4 months down the line. And we
Yeah.
need to treat that, identify early and treat as soon as possible, because if we do, it's reversible and it becomes resistant to therapies, and we lose that fibrotic effect from the lymphedema. What I believe happens is patients, they get a buildup of lymphedema. Most of the time, you go to see the surgeon at your 12 weeks PET scan. You go, oh, I've got a bit of swelling here. Oh, it's just radiotherapy. It'll settle.
Yeah.
Well, for many it does, but for many it doesn't, and it gets harder. And then if you start to develop radiation-induced fibrosis, which is a fibrotic progressive disorder due to fibrin and collagen being laid down, anything from 4 months, but it might not start for 20 years down the line. Okay.
Right.
So we don't know when it starts. Everybody's different. Um, and I've lost my train of thought now. But if we can, I believe that if we treat the lymphedema, try and keep that as
Yeah.
soft as possible, reduce those fibrotic changes there, get people onto some kind of rehab exercise program that will try and keep everything moving so we can stop the buildup of any fibrosis. I think that's the key. So I knew that some private lymphedema services do use photobiomodulation therapy, and
Yeah.
indeed the lymphedema team now I work directly underneath. That's the Derby team. They had an older device that's no longer in use, and I said, "Well, I want to try it." So I tried
Okay.
to look, is it safe? And I started to use it with our head and neck patients, and very quickly it became apparent. Well, first of all, it was they came twice a week for 6 weeks, and I thought, are these patients getting such an improvement in pain, lowered distress, wanting to go back to work? Is it because they are seeing me twice a week and they're having that therapeutic benefit of it? Doesn't, I don't mean me, but anybody who sits down with a patient and chats for half an hour twice a week, puts them solely at the centre, it's got a therapeutic benefit, hasn't it? So the
Yes.
next 12 patients we put through, I purposely didn't go in the room. You can administer it yourself for PBM
Yeah.
once you know what you're doing with it, and we got the same results. We have been getting patients off their feeding tube 13 years down the line, improving swallows we never thought to. Patients coming in with when they cannot move their neck, and then if they have the PBM alongside standard care. So standard care is by following the exercise program that we've delivered, or it might be some simple lymphatic drainage. So it's not just the PBM, but it certainly helps. We are getting amazing outcomes. So we've had about 150 patients go through now. Now, not just head and neck, majority are head and neck, but we do breast. We've done some vulva patients. We've done some peripheral neuropathy from the chemo, and we are getting really good results for many. There's only 10 patients that haven't had a benefit. Now, that's massive when there's been no benefit before. What we need regulation of this PBM, because now I've got patients trying to buy devices because they've heard me speak or they've heard
Oh,
about it,
right.
and it needs
Right.
regulating because there's always this. If you look at a lot of the papers, it talks about it's a cell proliferation. So can it help a cancer cell to grow? It says it's never been proved in human studies, but every single paper says patients must be informed. So there's things like
Right.
that you need to think about. So they need to be under a clinician who is monitoring to make sure that there's no red flag symptoms. But also, you can give yourself too much PBM. So it isn't
Can
just a
you?
case of let's just do this and be willy-nilly with it. And every device is different. A lot of these handheld devices are, well, we're literally not worth the paper that they're written on. They're not classed as medical devices.
Right.
So there is a lot of things that has to go into it, and that's something that we're going to be trying to work with some of the cancer centres in Europe who do these big PBM clinics. How can we regulate it? Is there a certification? I'm going to be presenting and trying to develop this diploma in PBM because we just don't know enough about it. Also,
Right.
whilst I'm also trying to apply for a research grant to prove that it is having an effect on fibrosis because nobody believes it. So a lot of the clinicians don't believe it until you can show those patient-reported outcomes, but that's really a patient saying, but the photographic clinical photographs that we've got of these necrotic neck ulcers that we're healing that have been through burns and plastics, been through dermatology, and they've not got anywhere with them, and we're now starting to heal them with this PBM. So
That's
I think
incredible. Can I
yeah,
can I offer myself at all to assist with any trials? Because I have radiation fibrosis in my neck. It's
yeah. I think the problem is
it,
I can't do anything is if you're not under Nottingham. So all the
right.
patients are, we are trying to. So myself and so Sabina Khan runs a late effects service purely for head and neck cancer down at UCLH
Yeah.
in London, and we are trying to get together to produce some best practice guidance on managing late effects of head and neck cancer. We've done them. I was part of it with Lisa Durrant when we did the pelvic radiation disease guidance as part of the Prada work. And that is what we're going to try and do. And hopefully we can get PBM into that as a guidance, but it's only ever going to be a guidance. We're not going to do a randomized controlled trial and say, right, you can have PBM and you can't, because actually everybody's radiation induced fibrosis progresses differently. So you're never,
Yes.
ever, ever going to be able to get a a reputable randomized control trial. But what I want to do is look at it at a cellular level. So we will irradiate some cells, cause the fibrosis, then put the BPM on and get it analysed and look at a cellular level. And then
Right.
maybe do say, I don't know, let's say 30 patients and they have an MRI scan before and after. They have
Yeah.
like, the swallowing assessments, the fees and the video fluoroscopies, they'll have that and we'll do their measurements because sometimes we're seeing some really small changes on swallowing assessments, but it's so significant to that patient.
Yes.
The other thing we don't
Yes.
know is it delaying the progression of fibrosis? And we won't know this until we follow these patients up for years and years down the line.
Correct. Yeah. 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 Yeah.
But its
What are you?
potential is amazing.
I totally agree, and I have been the beneficiary of the
Mm,
PVM,
yeah, yeah.
and I for one, and look, I back it all the way. It did wonders for me.
Mm,
Now, this is where I then go into the realm of placebo,
yep.
and placebo is a real thing.
mm,
It's not a real treatment,
mm,
but it's a real thing. Now, how you touched on something very earlier, very interesting. The fact that people come in and just talk to you about their late effects or the issues that
mm,
they've
mm,
got ongoing.
mm.
The fact they reach acceptance, the pain levels,
Yeah.
from a score of 0 to 10 go down, quite
Mm.
right. Um, but so talk to me about the placebo effect of people just coming to see you. Well,
It,
what's your view
I
on all of that?
of course, there's a placebo effect. There will be because we're listening to a patient and helping them to feel better. But you can
Yeah,
say that anything's got a placebo effect to it. PBM probably it absolutely has got a placebo effect to it. But we've got
yeah,
patients who haven't followed the exercise plan and have gone from being able to only drink 40 sips, and then they're now on egg sandwiches and nothing else
right,
has changed
right.
other than coming. Now, does it
Yeah,
because does that mean it's because we encourage them? They think, actually, I'm having that PBM, I'll try swallowing more. I don't know. And you know what? I don't
yeah,
care because at the end
no,
of the day, otherwise there is nothing else for these patients. So even if for the price of that, I mean, and I love the Thor device, but I've got other ones as well that I am trying. For the price of what that is, to the benefit that it gives to patients, phenomenal. The problem is how do we
yeah,
sustain it? Because
yeah,
I am already finding patients that are needing to come back because it's not lasting long enough. Well, of course
yeah,
it won't because fibrosis is progressive. So I
yeah,
think patients will need it at least every month for life, possibly, but we don't know.
yeah,
So it's
yeah.
how do we maintain that? But and I don't care if our services are the fluffy stuff where we sit and do that chat because actually we make a difference to patients' lives. And
That's the
if
bit
we
I'm
if
interested in.
yeah,
Yeah,
exactly. And
yeah,
I don't know, it's how do you quantify that? But
yeah,
actually, that's what gets me out of bed in the morning is, I
yes,
don't care. We do endless hours in these services, and most late effect services, they're run by one radiographer. So you've not got
right.
the support. But I'm lucky. We've got, I've got other advanced clinical practitioners now working in our service because we've been going so long. But often you're working on your own and you're seeing these patients day in, day out. It's a very lonely place to be. Hence why
Yeah,
we tried to set this, the specialist interest group up. But actually, what we get out from it is the difference that we make to patients. And
yes.
we get the odd one or two patients who really go and try every social media. Aren't they amazing? But that's what every single person in late effect services is experiencing. But just most patients don't go and sing about it. And I don't care. It can be placebo all it likes to be. But if I'm making that patient feel better at the end of the day, and whether I can
Yes.
quantify that or not, that's what
Yes.
it means to me.
And that's where I was going. It doesn't matter if you deliver PVM, placebo, or any other
No,
service or treatment.
yeah,
It doesn't matter if it works, it
no,
works.
yeah,
That's where I was going with that. Totally agree.
yeah.
What's the trust that you're funded by?
It's Nottingham University Hospitals Trust. So we're actually
So
the service is paid for by radiotherapy, basically. But if you think
right.
about it, we don't save radiotherapy any money because that's when you're having cancer treatment. But my wage
Yeah.
and comes from the radiotherapy budget. So it probably needs to sit somewhere else. But we are very fortunate here in Nottingham that we're very well supported by our radiotherapy manager and by the oncologists, and certainly a lot of the surgeons now throughout the trust who really believe in the service. Obviously, they can't pay us for it. It doesn't work like that. But yeah, but we've worked hard for that because back in
Yes.
2013 we were told, why do we need you? We don't need your service. We've got nurse specialists that deal with this.
Wow.
It's taken a
Yeah.
lot of brick walls, a lot of barriers to break down from other services, other professionals thinking we're stepping on their toes. We've really had to prove our worth.
Yes. And you established it in quite an amazing way. And I think you've set you've set your stall out, and you've also made yourself a valued, respected, independent department
Mm,
that works.
yeah.
So amazing work you've done. Thank you
Yeah,
and
I
well
would
done,
I
by the
would just
way.
like to say it was the head and neck oncologist, Dr. Judy Christian, who it was her idea for the service. She
Yeah.
doesn't see the patients, but she went and got all the Macmillan funding and has fought for us as a service every single step along the way. So it's really Dr. Judy Christian is the brains initially behind it, and obviously we're incredibly lucky that we had her to do that.
Is she still practicing now?
She is. She's one of the head and neck consultants. And everything I run by her, so all the photo biomodulation therapy, anything that's a little bit, off, she's there to help guide and provide that support with.
Brilliant. I just want to finish off on so with the amount of late effects available to any cancer survivor, that usually are not a matter of ifs, they're whens. I think is usually when is how I explain it. It's not if they crop up or occur, it's when they do. Um, what is changing in the way of forearming the patients about late effects, side effects?
Well, I think obviously the Royal College of Radiologists have changed all their consent forms. So, I mean, I don't know if you've still got a copy of your
Yes,
consent form that you had, but many patients probably don't
no,
keep it. But yes, so
no.
I think there's more of a percentage risk on these late effects now. So hopefully the conversation is happening earlier, and hopefully they're told about late effects services that are in their area and support, support that's available afterwards.
From so there's a lot of charities doing a lot of support
Yeah,
around this
yeah,
area as well.
yeah, absolutely, yeah, yeah, yeah. So obviously, charity, when late effect services work with charities, and
Yes,
but yeah, it's just about getting the word out there, isn't it? And
it is.
when back in 2013 there was a lot around the consequence of cancer treatment and living with and beyond cancer and the cancer
Yeah,
survivorship plan. Whilst it's all still there, things always still move back round to early diagnosis. I mean, I'm not going to bring politics into it, but there was absolutely nothing in the forward plan of any of the manifestos about late effects services, and it was all about early diagnosis. We'll get more treatment machines, we'll get more MRI scanners. Well, you can give as much more cancer treatment as you want to, and early diagnosis, you're still going to have these late effects. We know that
yes,
when we look at proton therapy. I have patients who have had proton therapy, and they are still coming back with late effects because the high dose of radiotherapy is where the high dose needs to be. Yes, you might not have as many late effects because you might not as radiate as much tissue, but you will
yeah.
always have those. Like we will never ever ever be able to mitigate the late effects of radiotherapy treatment.
No, agreed. And this is all about education, hence getting you on and hence having here the Royal Podcast. Emma, I just want to say thank you very much. It's been a fantastic interview. You're clearly doing some amazing work. Who is it? Judy, Dr. Judy,
Judith Christian, yeah, she's
Judith
one of the
Christian.
head and neck oncologists here at Nottingham.
Well, she's done some phenomenal work too. I will speak to you ongoing. Thank you for today. I'm going to wrap up. That was Emma Hallam, multi-award winning Macmillan radiographer-led consultant in the late effects clinic at Nottingham University Hospital. I think I got all of that right. Again, thanks, Emma. Fantastic interview. Great to have you on. This is Hear the Royal Podcast. I am Paul Schneider. You can follow us as always on Instagram on here.the.raw and on TikTok on here_the_raw. And we are available on nearly all podcast platforms, Apple, Spotify, Amazon. The list goes on. Emma, thanks again. And on to the next.
Thank you.
Thank you.